Good afternoon. My name is Dr. LaShawn McIver, and I'm the Director for the Centers for Medicare and Medicaid Services Office of Minority Health. I'd like to start by saying thank you to the National Academies for the opportunity to participate in this workshop on promoting health equity in cancer care. It is certainly my pleasure to speak with you today about the work of CMS OMH as it relates to the social determinants of health on cancer risk and outcomes. Next slide. I'd like to start by providing some additional background information about CMS Office of Minority Health. So our office serves as the principal advisor and coordinator to the agency for the special needs of minority and disadvantaged populations. And this includes providing leadership, vision, and direction to address CMS minority health and health disparities goals, as well as participating in the formulation of CMS policies and strategies. Next slide. Understanding the social determinants of health is an important part of ensuring we are meeting the needs of our beneficiaries and consumers. So our office is working to ground the agency in the common understanding of social determinants of health as established by the Healthy People 2030 framework shown here on this slide. We work across the agency to help ensure a shared understanding of the distinction between demographic data elements and social determinants of health information and its importance to our office's populations. For CMS, we consider each of the 5 domains of the social determinants of health and what levers we have within CMS programs and policies to ensure healthcare coverage and delivery of services is informed and tailored to provide the best care to our over 150 million individuals the agency serves based on each person's lived experience. Despite many advancements achieved in cancer prevention, detection, and treatment, there are groups who have not had the same improvement across the care continuum. So racial and ethnic minorities tend to experience more cancers than white populations, and communities that are medically underserved lack access to sufficient cancer care due to social determinants of health. For example, underserved populations may live in food deserts, a neighborhood that has limited public transportation, or an area that has higher air pollution, and all of these factors can increase the burden of disease and create additional barriers when accessing preventive and treatment services. Next slide. One of the biggest challenges with understanding the drivers of disparities is the lack of SDOH data. So we know that demographics matter, but disparities can be caused or exacerbated by social determinants of health. And so it's critically important to have data to help us understand more about the populations we serve and the barriers they face in accessing care and achieving optimal health. CMS certainly has a role in helping to align and increase the collection of SDOH data, and some of our efforts are noted here. Our work in this area aligns again with Healthy People 2030 objectives around healthcare access and quality, particularly objectives related to health IT, healthcare, and health communication. So for example, we work with our federal partners as well as private-public partnerships such as the Gravity Project to support the standardization of demographic and social determinants of health data elements across federal programs and healthcare systems. As data is more standardized, we also work across CMS to increase the collection of standardized demographic and SDOH data elements. A few examples of our work that supports older adults are strengthening standardized demographic and SDOH data collection in the Medicare Current Beneficiary Survey, the SPADE assessments in post-acute care settings, and ICD-10 CM-Z codes. We also support analysis and reporting related to demographic and SDOH data in a few ways. For example, our annual stratified reports and our Mapping Medicare Disparities tool have Medicare fee-for-service and Medicare Advantage data stratified by race and ethnicity and geography. We also analyze claims data and publish reports and snapshots to increase understanding around social determinants of health that are commonly coded in claims, breaking out where social determinants data is available for older adults and where that information differs across populations we serve. And finally, we collaborate across the agency to provide tools, outreach, and education to care teams and health organizations around how to collect and use standardized demographic and SDOH data elements to drive improvements in care and health outcomes. So the graphic on the right is part of our is an infographic we have on our website to help increase the uptake of ICD-10 CM SDOH Z codes and help providers understand how to use SDOH data they have to improve care. Next slide. We provide technical assistance to organizations who are working on health disparities, and because we know there's not a one size that fits all, we provide one-to-one technical assistance and consults. So any organization can email us for a single call for help with a disparities related question. For example, if you're looking for resources or guidance on how to collect or analyze data, how to begin a cancer treatment quality improvement activity, interventions for a particular population or type of provider, or how to create a health equity governance structure. So you can email us at healthequityta@cms.hhs.gov. Next slide. So lastly, I will just talk about some of the data resources that we have available. And I will be going over some of CMS's chronic condition warehouse data related to cancer, as well as data from our Mapping Medicare Disparities tool. In addition to working across CMS's policy efforts and programs to embed an equity lens inclusive of SDOH, our office utilizes data we have available to better understand disparities related to individuals with cancer, as well as create tools for others to use. On this slide, we have cancer trends among Medicare fee-for-service beneficiaries taken from our chronic condition data warehouse. As you can see here, the rate for female breast cancer has risen slightly over time from 4.9% in 2009 to 6% in 2018. The rate of prostate cancer fluctuated somewhat from a high of 7.5% in 2011 to a low of 7% in 2014, and then to 7.3% in 2008. And then here, the last point around rates of lung and colorectal cancer were stable over time. So this is one of the resources that we have accessible to us to understand disparities for people with cancer. Next slide. This slide shows that in 2019, the prevalence of prostate cancer among male Medicare beneficiaries is higher for African-American men. This data was taken from our Mapping Medicare Disparities tool, and I encourage you all to visit our website to explore this valuable resource. This tool provides a granular lens into chronic conditions by identifying areas of disparities between subgroups of Medicare beneficiaries. So for example, racial and ethnic groups, age and sex, and health outcomes, utilization and spending. This information may be used to inform policy decisions and to target populations and geographies for potential interventions. Last slide, please, or next slide. And then here again, we have another example. This chart shows the prevalence of breast cancer among female Medicare fee-for-service beneficiaries by race and ethnicity from 2019. Next slide. In closing, again, I'd like to say thank you to the National Academies for the opportunity today to share what our office is doing related to SDOH and cancer. I encourage you to reach out to us. We have several mailboxes listed here. The main one is omh@cms.hhs.gov. We'd love to hear from you. So we encourage you to contact us and visit our website, which is also listed here. Thank you so much for your time, and I look forward to the discussion ahead.